Hello, everyone, and welcome. I'm Jen DeYoung, Senior Director with United States of Care, leading up our Innovation Lab. I'm thrilled to partner with West Health today to bring you this webinar looking at older adults' experience with virtual care. United States of Care is a nonpartisan, nonprofit organization that is committed to expanding access to quality, affordable healthcare. At US of Care, we drive change at the state and federal level in partnership with everyday people, business leaders, healthcare innovators, fellow advocates, and policymakers. Over the past 2 years, we have seen the COVID-19 pandemic response unleash a revolutionary expansion in virtual care, whether it be telehealth, remote monitoring, or other remote forms of communication. Virtual care tools are shiny and new for many, but at US of Care, we're looking beyond the present to the potential it has for being a long-term lasting solution to close gaps, address barriers, and get more people access to the care they need. As part of our work, we've partnered with West Health to look at the experience older adults have had using virtual care. What's worked well, what hasn't, and what do providers and policymakers need to know to make it a more equitable experience? I'd like to introduce you all now to my co-host for today, Amy Herr, Director of Policy at West Health. Welcome, Amy.
Thank you, Jen. Great to be here. We're so excited to be here to share our findings today. As Jen mentioned, I'm Amy Herr, Director of Health Policy for West Health. And West Health is a family of organizations focused on lowering the cost of healthcare to enable seniors to age in the place they want, and with the access to healthcare services and social services that they need to support living independently. I'm really happy to co-host today's session. As Jen mentioned, our findings build off some work we've done over the past 2 years, and we're really excited to build on the work that we published last year. And I think, as we all know, telehealth was such a very minuscule part of the healthcare system before the pandemic, and then it just exploded. And we've really seen a leveling off, which we think is the sweet spot. So we're really excited to help policymakers figure out how to keep the best parts and do away with the rest, and really figure out the right way to promote telehealth and virtual care going forward. We will be having a playbook that we publish that is associated with this webinar and findings. It'll be on our website in shortly, and we'll make sure that all the webinar participants get a link to that playbook when it comes out. And I just wanted to give everyone a short overview of today's webinar session. So we're going to start with Jen DeYoung, will provide some research findings from our project. We just have a couple slides, but wanted to show you what we found in our work. And then we'll move to me. I'm going to moderate a fireside chat with 5 organizations that have successfully integrated virtual care for older adults into their programs. So really excited about that. And then we'll turn back to Jen for closing remarks. So let's get started.
Thanks, Amy. So I wanted to start our conversation today by sharing some background on what the virtual care landscape has been like in the US to just get us all grounded in the discussion. As Amy mentioned, pre-pandemic, so prior to 2020, we were seeing a huge demographic shift as people are living longer and they're needing more extended healthcare services from an already tapped system. Meanwhile, the only option really was in-person care for many people. At the time, we were seeing only 0.1% of Medicare primary care visits being provided via telehealth. And then COVID hit, and we saw this surge in telehealth usage for all populations as people and providers looked for alternative ways to get people the care they needed. To help with this, a lot of the restrictions around telehealth use got lifted under the public health emergency. And by April 2020, we were seeing 43.5% of Medicare primary care visits being provided through telehealth. And now we're in the second year of the pandemic, and we're starting to see the spike in telehealth use level off, as Amy had mentioned, as people are becoming more comfortable being back in person. And we don't have the Medicare data quite yet, but as I'll share in the next couple of slides, and as you'll hear from our panel later on, people are gravitating towards wanting a mix of in-person and virtual care. And we're seeing healthcare organizations respond by finding really innovative ways to embed virtual care into their model of care for the future. So I mentioned earlier, and Amy did as well, that US of Care and West Health, we worked together on a study looking at older adults' use of virtual care. And this slide here lays out our approach for it. Our key question that we centered around is how can virtual care close gaps in access to care and health inequities for older adults? And to do this work, we conducted mixed method research, which involved doing our own national survey with West Health in 2021 and then again in 2022. We also reviewed public opinion scans and hosted focus groups, among other activities. And we also looked at several organizations as case studies for how they provided virtual care to meet their older adults population's needs during the pandemic. And you'll be hearing from these organizations later today. And then we took all that information and identified action steps for healthcare leaders and policymakers. So overall, here's a really high-level summary of what we found. The bottom line is people like virtual care, and this has been a consistent theme throughout the pandemic. For the next couple of slides, I'm just going to dig in a little deeper for you on each of these findings for you. So this slide here gives you a snapshot of our data on who is using virtual care. Most people have used it, and a majority of those using virtual care have done so 2 times or more since the start of the pandemic. Our poll also found that most older adults' virtual care visits occurred mainly with their primary care provider. However, we found differences between age groups when it comes to which providers older adults saw. Those aged 50 to 64 were more likely to have seen a mental health professional, while those 65 plus were more likely to have seen a specialist virtually. This slide here looks at trends in satisfaction with virtual care. And as you can see, older adults like virtual care, including the convenience of not having to leave home, avoiding crowds, and more scheduling options. And while it's helpful to us to understand what people like about virtual care, what's also helpful is to understand why people are not using virtual care, or if they have used it, what are the challenges they experience with using it? Through our research, we identified 5 main barriers from people: concerns around health data privacy, comfort with using technology, having access to reliable and accessible internet, concerns around whether their visit would be high quality and personalized to meet their needs, and concerns around whether they could get an accurate assessment. So I want to look at each of these slides individually with you so you can see the data we got on it. First off, a number of older adults reported not having or not being comfortable with various forms of technology. Similarly, in more prominent and rural areas were issues older adults had with accessing reliable internet services for their virtual care visits. People also had concerns that the provider might miss something, or felt the provider couldn't get an accurate assessment, or just generally felt that the virtual visit wasn't very personable. And something we saw new this year was an increasing concern among older adults who have not used virtual care because they had concerns around privacy of their health data. The main concern they held was around the privacy of their health data and integration with electronic medical records. And the second leading concern was that the provider could not be in a private location for the visit, followed by needing assistance from another person, hindering privacy. And some of these concerns were felt slightly more among the adults aged 65 plus. So after looking at what people like and don't like about virtual care, what's most instructive is whether people would want to continue to use it into the future. And as you can see, most people favored wanting a blended option of in-person and virtual services. However, we saw differences in the age groups. About a third of older adults aged 65 plus said they would not continue using virtual care services after the pandemic if they had a choice of in-person visits. On the contrary, about a quarter of respondents aged 50 to 64 said that they would use virtual care more often to seek healthcare services if they were given a choice. So as part of our research, not only did we gather data on people's experience with virtual care, we also profiled several organizations who incorporated virtual care into their practice as a way to meet people's needs during COVID, and looked at how they took innovative steps to address their patients' barriers. You'll get to hear more from these organizations as part of our panel discussion in just a bit. But before we go there, I wanted to share the recommendations that came out of our work. So this slide here lays out the key insights we had for healthcare providers. I'm not going to go through each of them, but you can see that they range from adopting a value-based payment model. Specifically, we found that value-based payment models, which reward for providers based on patient health outcomes achieved rather than the number of services provided, they offered maximum flexibility to provide virtual care services to older adults. And another insight on this list was creating transparency for a successful blended care model. So really making sure to communicate clearly with patients which types of services can be conducted virtually versus in person and why. That transparency about blended care decisions builds trust in patients that they're receiving the highest quality of care. More details on each of these insights you'll be able to find in our upcoming playbook publication that Amy mentioned at the start. And lastly, we also had several recommendations for policy action. First, within a value-based payment model, offer a mix of in-person and virtual care. So when clinically appropriate, older adults should have the flexibility to choose whether to receive in-person or virtual care. And second, for individuals with complex needs, identify additional support to enable virtual care. And this could include making an audio-only option available, using telepresenters to facilitate patient access to virtual care platforms, and incorporating strategies for patient-centered healthcare. And third, research the quality, cost, and equity implications of virtual care models compared to and/or in addition to in-person care for different populations and geographies. So with that, I am going to pause and turn the screen over to Amy, who's going to introduce us to our panelists and lead us in our discussion.
Great, thank you so much, Jen. We're really excited for the fireside chat that we have right now with 4 organizations that have been using virtual care for their older adult populations and have adapted their practices over the past 2 years to really meet the needs of older adults. So first we have David Fletcher, Associate Vice President, the Center for Telehealth at Geisinger. And Geisinger is a fully integrated hospital and clinic system located in Pennsylvania. Next, we have Josh Hoffmeyer. Josh is Vice President and General Manager for Senior Care Services at Avell eCare, which is a service virtual care program for seniors with a significant reach in rural areas. Next, we have Mike Kurland, Director of Telehealth and Process Improvement at West Health. And Mike will be talking about Gary and Mary West PACE, which is a fully integrated program for all-inclusive care for the elderly in Northern San Diego. And finally, we have Greg Snyder, Vice President for Clinical Strategy and Quality Improvement at Medically Home. And Medically Home is an acute care hospital at home services company that partners with health systems to co-operate virtual hospitals, decentralizing care into patients' homes. So thank you so much for being here. So we want to start with a little bit of an overview from each of the panelists. And I wanted to hear a little bit about, now that we're 2 years into the pandemic, what have you experienced and how has your use of virtual care services changed to meet the needs of older adults? So we'll start with Mike at West PACE.
Thank you, Amy and Jen. It's a pleasure to be here on the panel with everybody else. I have to say, just like as a fan, I'm really interested in hearing what everyone else has to say because it's a really innovative set of organizations with some really awesome leaders that I'm co-speaking with. So I'm pretty stoked just listening. A little bit about PACE for folks that just don't know about it. Imagine a program that is pretty much 100% at risk for nursing home eligible patients that you just try to keep at home and try to keep healthy and out of the hospital. That's what PACE is. So I'll give you an example. If someone needed an air conditioner to help them stay healthy, PACE can do that. They can provide an air conditioner. They can build a ramp. They could also send services to the person's home. And there's usually a clinic associated with PACE. And the idea is that you're getting these participants to come into the clinic when you need to. The challenges with these patients, and they're called participants, as part of PACE, it's just kind of like the nomenclature. So I might say participants. The challenge is around travel a lot. So you could imagine that if you're a nursing home eligible patient or participant, that you are elderly, fragile, and that you're not always going to want to travel. And sometimes travel could be anywhere between like 30 and 60 minutes. So it's not unusual that patients may cancel at the last second, that it's hard to kind of get them to come in when you really do need to see them. So PACE has to incorporate like different strategies in order to see these patients and meet their needs. And one of those needs is like, oh, how do we get around this travel issue? And so one strategy that we incorporated right when the pandemic hit was bringing in specialties that can see the patient virtually. And the one that really has like kind of stuck, that really has taken off, and to probably no surprise to anyone that's listening, has been like mental and behavioral health. And if I'm being really honest with the folks on this call and all the panelists, I think it stands out from other specialties because the providers of that mental health and behavioral health clinic, they were really committed out of the gate to stay with behavioral health and telehealth. Other specialties that like we contract with other major hospitals and healthcare organizations in the area. And they also kind of like slammed in telehealth during the pandemic. And there was a level of like, yes, we're committed to it. And then like Amy and Jen said, like it kind of like dropped off. And it's like leveling out, but it's leveled out to the degree where it's like, we're doing onesies and twosies with other specialties. So the real takeaway for us is like, when we're engaging with like these clinics and practices that are providing specialty services, for instance, we really need to hit it out of the gate around telehealth engagement and how does that happen from a scheduling perspective. Other things that kind of like have helped, and I'll get into a challenge real quick and to go to the other panelists, is that we started using e-consults, and that's really stuck. And e-consults is basically this provider to provider kind of like specialty consultation. And that's been great in helping us kind of avoid having to schedule the specialist just to answer one or two simple questions that our own providers can address with a little bit of guidance. The other thing that we've incorporated is an interesting contract with an organization that goes out to participants' homes and it provides like urgent or acute care. It's like urgent care on wheels, if you will. They could do wound care, they could do change of condition assessment, like post-falls. And there's been a few instances where this clinician, which is typically an RN, beams in to like, beams the provider from the clinic in and says, hey, does this person, are they okay to like maybe come into the clinic tomorrow based on our assessment, or should they go to the ED right now? Or can we treat them at home? And that's been really successful in helping avert some like what would have just been a kind of a reflexive ED transport. And what we're also trying to do is get some telefacilitators in to do other things, but I can get to that a little bit later. I have to tell you, one of the challenges is, and it's around the telefacilitator, is staffing. I don't know about you and your organizations, but staffing was an issue before the pandemic, but the pandemic exacerbated it, and finding clinicians that can help kind of co-facilitate some of these visits has been a real challenge. And I can get into some of the opportunities that we're currently missing out on until we get some of that staff.
Great, thank you, Mike. I'm really excited that we have another panelist that joined us. Christopher Stark is the Chief Clinical Officer at Landmark Health. And Landmark provides longitudinal and palliative in-home geriatric care, including behavioral health and urgent care services. So actually, I'll turn over to you, Chris. Now that we're 2 years into the pandemic, how has your use of virtual care changed for your population?
All right, thanks. I apologize to everybody for being late. I'm in the middle of like a hurricane here in the Panhandle. It's not really, but I got off a plane and got into a torrential downpour. So I apologize for being in a car and looking like this. So, but yeah, Landmark Health is a geriatric specialist physician group where we do a combination of in-home care as well as televideo and telephonic care to bring all sorts of services into the home for a very acute, sick population of patients. They're typically 6 or more chronic medical conditions, 13 or more medications. Our average age is in the high 70s. And they have 4 to 6 specialists apiece. So we take these groups of people and do a combination of in-home care for longitudinal care. So we'll make appointments and see people in their homes to deprescribe. We'll try and optimize their home medical care. We'll also run an urgent care on wheels, much like you, Mike, where we'll go to the patient's home. We carry IV fluids, we do suturing, we do nosebleeds, and a whole variety of breathing treatments and anything else that can be a low budget ER visit or an urgent care type visit. And we can run those visits right in the house. And we're as well a at-risk corporation. So when the pandemic hit, so we were almost 100% face-to-face in-home care with our behavioral health wings, our social workers, our ambassadors, and all of our providers going in the home to see people. When the pandemic hit, we shut down, just like everybody else, for PPE and everything else, the home care for about 3 months and switched to 100% televideo and telephonic care. Then as we got PPE, we started to find that happy place. We started to move from where did we need to see people face-to-face versus where did we need to see them from a televideo, telephonic route. And we've gotten to about an 80-20 split of face-to-face visits and televideo visits for our patient population, which we find really helps keep them happy, healthy, and at home as much as possible. But we found lots and lots of challenges in those 3 months, as well as in the continuing training people how to do televideo visits. What kind of physical exams can you do? What kind of diagnoses can you make over the phone and over video? What can you do to treat them at home, utilizing family, utilizing what we call our Gentivis extenders, which are a lot like what you do, Mike, with RNs, LPNs, and paramedics going into the home, doing a televideo assisted visit with our own nurse practitioners in our call center. And then if that doesn't work, we have our own providers in the market that will go locally to go see those people face to face. But trying to train people how to do the videos, how to look professional on video, unlike myself today, and how to have good backgrounds and good lighting and make sure your internet is up and running and your equipment is good, and make sure all those challenges that we have living in the virtual world these days to train providers who are used to going to see people face to face.
Great, thank you so much, Chris.
Hopefully I answered your question, Amy.
Yeah, that's great. I appreciate it. So I wanted to turn to David next. And one of our questions is around what do patients like or dislike about virtual care, and how is Geisinger address that?
Sure, yeah. So, we've done a lot of surveys in our area as well. And we've seen very high satisfaction for our patients who use telemedicine. And I think most health systems have, we're generally in the upper 80s, low 90s. And and that includes all ages. We look specifically at the 65 plus age group, and they've got high satisfaction. It's not quite as high as the younger population, but when we look at our older population to other older populations across the country, we've seen a little bit higher satisfaction for our patients. And I think it's because we designed our process where our patients don't go through a portal or a registration process to get their telemedicine visit. We really just send them a link, and they click on that link and they go right into the video visit, because we have all the integration with our EMR. And so I think that has helped. We've kind of stabilized the satisfaction scores across the demographics a little better than I'd initially hoped, honestly. And I think, generally the things that patients like are the things that you would intuitively assume. They're not having to travel, not being in a waiting room with other folks who have, could have COVID, things like that. Now, when we asked those patients, okay, great, you love it, you're highly satisfied with it, do you plan to use telemedicine going forward? Much like the data we saw earlier, we saw it being lower than the satisfaction score would lead you to believe. And so we asked, okay, well, what concerns, if any, would you have about using telemedicine going forward? And what we found was the highest response on that was, I'm just concerned that it may not be as comprehensive an exam as in person. And so I think that's where we've been putting a lot of effort, is really educating the patients. I think there was a bit of an assumption that, hey, this was an emergency measure just to get us by through COVID, and then once it's over, we're going to get back to just going in the clinics. And so I think we've been putting out videos of some of our doctors talking about instances where they like to use telemedicine, but also I think equally important is instances where they don't like to use telemedicine. And we're really diving into the data now to really understand, what does it mean? I think there are a lot of studies out there that show kind of equivalence between a telemedicine and an in-person visit for the visit itself, but what does it mean downstream? Are there any impact to the way that a patient might navigate the health system if they have certain visits via telemedicine? And I think we had it in mind to share that data with policymakers and our providers, but I think it's equally important to be really transparent and share that with the patients as well. And so they understand, if we won't offer telemedicine unless it's clinically appropriate, and we kind of have some data to back that up.
Great, thank you. Josh or Greg, do you want to weigh in on what patients like or dislike about virtual care? And
Happy
how your
to.
organization?
Yeah. I think that when we think about patients medically home in terms of home-based acute care, post-acute care, home-based emergency department in the home care, and transitional care, I think it's helpful to clarify that when we bring patients into these models, and specifically for home hospital, that they're really opting into a model of care that is and begins with acute care in the home. And in our model, I'm referencing some of the comments made earlier because it's fascinating to me the way in which over the course of the pandemic, there has been a blend of virtual care tethered to in-home clinical providers. That is a crucial part of our model of care, where we would have a telemedical command center that is tethered to providers of clinical services in the home. And you need that for acute care in the home. So to your question around how patients participate in and experience virtual care, to our patients, virtual care is a blend of telemedical care and in-person care. And to clarify, 100% of our physician video visits are virtual. 100% of our RN visits for the primary bedside RN of a patient are virtual. And then those clinicians are complemented by providers that go into the home on an as-needed basis as part of that care team, or providers of clinical services that are tethered to those telemedical providers in the home. And so patients really experience virtual care in terms of what we're doing now, speaking to providers on video, and appreciate that for really the strengths of what I view to be medical care in the hospital, that is history taking and learning about patients through what they're telling us, less our physical exams. Of course, our physical exam remotely is then augmented by a provider that's tethered into the home. And so the patient's experience of virtual care is of that tethering. So that's our focus. And I think that is very different for an acute hospital substitution patient, where we're taking a patient out of an emergency department, off of a medical surgical floor, out of a skilled nursing facility, for instance, as compared to an emergency department or urgent care in the home visit. The blend of in-person or virtual care in those models is slightly different, but the patient's experience is still of a blend.
Great, thanks so much, Greg. I wanted to turn to you, Josh, to talk about patients in your model, but especially efforts that your organization has done to assist patients that are experiencing barriers to virtual care.
Yeah, thanks, Amy. Great to be with everyone today. So at Avell eCare, we've been providing telemedicine services for nearly 30 years across a variety of settings. And so as you can imagine, as we've deployed over 30 years and we have numerous different types of telehealth that we provide, we've come across a lot of different barriers and had to get creative and innovative on how can we help overcome those barriers and move forward, because we know that access is an issue across the country in rural and urban areas, and telemedicine can really help fill in those access gaps. It's also a big support for clinicians that are out in the field and may just feel the overarching burden of so much to get done in a day, and how can we help support them. And so getting past those barriers and making sure that these services are there to help take care of patients is definitely important. As I look at the services we provide for seniors, we have telemedicine programs that we roll out into skilled nursing facilities and long-term care sites, assisted living, independent living, and we also do some home health. All of ours come with a kit that works off of typically wireless signals, once in a while cell phone signals if we need to go that route instead, to allow our clinicians to both see and interact audio wise with the patient, but also use different peripherals such as the stethoscope and otoscope to help do a full assessment. And so with doing that work, some of the barriers that we typically see, one of the first ones always is that connectivity. And how do we ensure that that connection is there and that we can have that when we need it? And so we've done spent a lot of time looking at the different types of equipment that are out there, the different connectivity methods, and really try to find those that are simplest, if there is such a thing with some of this connectivity stuff, to really do those interactions and make it as easy as possible on both the clinician and the patient that we're serving. So from the start, making sure that connectivity is there or working through that hurdle is really important. You don't want to implement a telemedicine solution and then go to do your first encounter and realize that the connectivity doesn't work. Even if you have all your I's dotted and T's crossed, there's still going to be times where the connectivity doesn't work for a variety of reasons. And then making sure you have some backup plans to be able to do that then is important to overcoming that barrier. Another barrier that we sometimes see is just the adoption rate of sites that we go and partner with. It's a big change when we bring telemedicine services into a skilled nursing facility or a senior living campus. And so getting the staff and the residents and their families and also the community as a whole on board in understanding what it is that we are doing and what the goals of the program are really important. And so as part of our overall implementation process, we have a lot of different steps that we take with each of those groups of people that I mentioned to make sure that they understand what the program is, why the program is coming to their community, how it's going to benefit them, how it's going to benefit their primary care physician, and it's not a replacement of their primary care physician, and things along those lines. So there's a lot of other minor barriers that you run into as well, but I would say those two really cover the top that we see a lot of times.
Great, thanks so much, Josh.
Yeah, Josh, connectivity is always the huge issue of trying to get in with these patients. A lot of them don't have internet. They have cell phones. So everyone has a phone that you can get into it, but if you really want to get televideo and get that connectivity, that becomes a real challenge, especially with the geriatric age group that a lot of us are seeing at this point, especially with our risk cohorts. And trying to get equipment or chip enabled devices and things like that into these homes is a challenge. So some of us have hired people that go out to do the video assisted visits with those providers. Some of them, we do the best we can to hook up the patients, and the different ways that they log into those platforms is a challenge. Like our technology was app-based, which wasn't really good because they didn't remember their passwords. So they couldn't download the apps because they didn't remember their passwords. We find a lot more success with the link type of systems where you can text them a link and all they have to do is hit the link and then suddenly they're in the platform. So that with the HIPAA that was dropped during the pandemic emergency, where you could use WhatsApp, you could use FaceTime, those types of things really helped out a lot for a while because they were all talking to their grandkids on FaceTime. But now they've just started to take away some of those leniencies. So I just was alerted that a state like Mississippi just got rid of the ability to use the non-secure, HIPAA secure platforms. So you can't use WhatsApp, you can't use FaceTime anymore. So we're going to start running into more connectivity challenges again, the more and more states release those emergency mandates.
So I love that you're talking about connectivity challenges as you sit in a monsoon in the Panhandle and have perfect video connection. It's so wonderful, and I think there's been such great progression in that space. We certainly agree that as a part of this type of care, it's table stakes to really augment connectivity, and to Josh's excellent point, I think that the design and implementation of these systems and then installation of the right systems is just as important as the coverage. And when we admit a patient in the setting of acute care into the home, there is a technology installation process where we're putting in the biometrics and the redundancy and connectivity. And then the communications technology is not just video, it's also phone-based connectivity, it's personal emergency response systems, all in the setting and service of acute care, to be clear, which I recognize is different, but I think that there's a common thread of the need for redundancy and connectivity and communication modality across here. And then I think there is the question of how to break down the barrier of technical literacy with patients, right? As you're implementing and installing that technology, there's the opportunity to really engage a patient in understanding their level of technical literacy, and then teaching and teaching and hearing back from them what they need help with. Medically Home, we work with a lot of provider systems. Those are our partners. And so at times this will be both technical literacy education around the system that we're using now, and potentially portal adoption for further virtual care in the future after the episode. I just say that as we look to sort of how to take care of frail elderly patients, because I think there's also opportunity to use telepresenters or technology installers or that tethered personnel in the home to also understand social determinants of health, the built environment, the home safety, the caregiver burden, all of the things that really make a difference in terms of preventing episodic care.
Great, thank you. I wanted to move then to providers, and whether you've had resistance from providers or what you've had to do to help train your providers and really get them organized and comfortable with using virtual care. And I know, Chris, you mentioned at the very top of the call about, not being in a car, but having a background or having like a professional place to do a video call. What are their barriers and solutions have you found for providers?
I think for the providers was a lot of it was just getting thrown into it very, very quickly. Just from one day you were seeing patients in the home to the next day you were 100% virtual with your kids that were now not going to daycare and the dogs that are running around in the house that you're not used to having in your working environment. So training them how to separate their working environment from their living environment, to make a professional type of background, a professional type of lighting, so that people look at you and see you as a professional. They don't see you sitting in a car in a monsoon in a polo shirt. They see you in a tie and in a jacket, in a nice environment with books behind you that looks like what you would expect a provider to be seeing their patient in, because the extension around you is the extension of your office, since this virtual environment is now your office. And teaching them the skills of what can you do and what can you evaluate in the patient and what can't you evaluate in the patient? What do you need that person in the home to do? So you have some drawbacks and you have some benefits to it. You can see a lot more people a lot more efficiently. You can jump on with somebody that has an urgent need and not have to have that 45-minute drive to their house and the 45-minute drive back. That takes a lot of care out of their systems. But the internet wasn't designed to do this. So a lot of them needed upgrades of their Wi-Fi systems. They needed different equipment in the home. They wound up getting multiple screens, holders for their cell phones, so that they weren't holding them out with their hands shaking while they're trying to type and do other things along with the visit. So there were lots and lots of challenges, along with the IT things that we've mentioned before, is just developing systems and figuring out the best way to do it. You know, we developed our own app from the ground up and figured out it wasn't the best app. It wasn't the best system to use. And learning and modifying and bending is what we had to do as a company, from the provider level all the way up to IT and management. We all had to figure out how to bend to this new environment. And I think overall we're showing that this environment excels at helping us take care of patients. It's a tool, but it's a valuable tool.
Amy, I'm sure David could probably give a little bit more insight into this too. But you know, I think the behavioral management and change management aspect of it has been quite challenging. Yes, during the pandemic, everyone kind of stretched and did something different to accommodate, their own work environment and, patient safety. And they transitioned a lot to video, phone calls, did whatever needed to be done. But as things subsided, everyone got vaccinated, you got PPE, you see this kind of reflexive behavioral, change to go back to where things were comfortable and things were like they were before the pandemic, seeing most of my patients in the clinic. And although I have some, champions and believers of it, I also have some of the folks that are like, oh, okay, yeah, so we're still trying to do this telehealth thing. And it does require some education, just kind of require reinforcement of the pros and cons that everyone on this panel had mentioned already. I'm just wondering if David has experienced something like that as well.
Yeah, absolutely. So I mean that was a big sea change for, pre-COVID. Almost every telehealth program we had came because a provider or a specialty was really interested in it, and kind of by definition we had actively engaged providers. And now it's just a standard of care. We went from less than 1% of our visits being telemedicine to over 10% now of our outpatient visits. So 20 specialties to 70 specialties. So the majority now of our providers who are doing telemedicine don't really care about telemedicine either way. So if it's a barrier, if it has problems, the answer is we'll just have them come into the clinic. I'm not invested in telemedicine. And so the key I think that we found is we've got to really build those integrations. So our providers, they're in our EMR all day. Everything's got to integrate with that EMR. And I think that's one of the things I really emphasize to vendors who come. They may have a great product, a great idea, but if everybody has their own separate portal and expects the doctors to sign into one of 20 different portals all day, every day, it's never going to happen. And so we see, even within a single specialty, wide variation from doctor to doctor of telemedicine uptake. So I think it's, in a way, the bigger challenge, even than on the patient side, is the provider side. And we've got to make it really easy and seamless for the providers. And generally the patients, they trust their providers. And so if the providers are enthusiastic about it, the patients will be as well, by and large.
Great, thank you. I wanted to move to the role of caregivers and family caregivers and how they can support your patients, and wanted to start with Greg about how virtual care has helped or hurt the role of the family caregiver.
Yes, thank you, Amy. I think that for us, I'll speak specifically about home hospital because I think it's a little different from what we're thinking about in the ambulatory virtual care space. When we admit a patient for a virtual home hospital episode, we're admitting both that patient and their family and their caregiver, right? We're doing video visits with them, but we're also sending providers of clinical service to their home. And those visits are happening actually more frequently than they may occur in the brick and mortar setting for certain service categories. And so the family, if they are there, is a part of the care. And so that's a part of the consent process for how we assess and then consent patients for the model of care. To be clear, you do not need to have a family member or caregiver for this model of care. And so where there is lack of caregiver support or interest in supporting or burden in the home, we support that through the rapid response supply chain and services network that we have to build as part of this acute care, home-based care infrastructure. And we do that through home health aides, providers of service going into the home for manual therapies, PT, OT, speech therapy, home-based nursing. And so, we first have to assess caregiver support before we even admit a patient, so to speak, if you will. And then as we assess that, we have to understand the caregiver's ability or willingness to participate in care. We assume that they are not able or willing to as we provide those services to patients. But where they are, we see a lot of strength. We see that a caregiver can be very helpful in managing chronic disease burden during even an acute care episode, can be helpful in us understanding goals of care for a patient in the setting of acute illness, especially as they would in the brick and mortar hospital, a healthcare proxy, for instance. And so we have to really assess a caregiver's willingness or ability to participate in the model. We also include them, by the way, in that technology literacy piece that I was speaking about before, because if a patient in the virtual home hospital is acutely ill with sepsis and decompensates at home, that patient will have many opportunities for us to check in with them, for them to check in with us, to press a personal emergency response device. But it's equally important that all of our providers of service and the caregivers in the home know how to do that as well, should they sort of be the first to notice a decline. And so that's all built into the way that we think around this. I guess my overarching point is that caregivers, when they are able and willing, are a part of our multidisciplinary care team.
Great, thank you. Great, I wanted to talk about how virtual care can be a tool or can be used to reduce healthcare disparities. Because one of our key messages from the playbook is that if implemented the right way, we really have an opportunity to reduce health disparities. And so I wanted to start with Chris about how you see the use of virtual care reducing health disparities.
Yeah, so when we talk about social determinants of health, there's a variety of ways that virtual care really can assist with that. So when we're in the home, when we're seeing patients face to face in their environments, we see an awful lot of the environments that they live in, the neighborhoods they live in, the different challenges that they have. You start to lose some of that with the virtual world that you can't see around you as much, but the tools themselves allow us to see patients where there's transportation issues, where they live in deserts of different areas and different, resources that they have. And this allows our providers to get into those environments much more often, to give them supportive care in behavioral health, supportive care with social workers, with the providers, just to be able to get into areas where normally those people have difficulty coming out to clinics. They have difficulties getting care, and they can have varieties of care that they normally wouldn't have had because they can get to specialists now that are nowhere near where they live. They can talk, get second opinions and third opinions, and they can have their families looped in so that they get the educational component of it all. The whole family gets educated and not just the patient. I mean, I think we've talked throughout this entire panel session about different social determinants of health, just in different little aspects throughout the entire process. But the education, the financial, the transportation, all those things are highly benefited by the virtual world, as long as we can get the technology into the homes in different ways, which we've already talked about.
Great, thank you, Chris. Does anyone else want to comment on reducing health disparities?
Amy, I'd say that, you know, in our view, virtual care is a tool to use to decentralize care. And decentralizing care is really what addresses social drivers and social determinants. And so, you know, taking patients out of facility-based settings and putting them in the home or in the right site for the care needs that they have. Because I think that, to some of the earlier points by Chris and Mike and David and others, allows us to really understand, you know, a patient's socioeconomic vulnerability, their education and access to care, their access to the quality of care that they need, and then all of the home-based and built environment drivers that lead to so much recidivism and excess utilization of acute care. And so virtual care, you know, its ability to drive change in social drivers, in my view, is really in allowing for us to put patients where they are and where they live so that we can meet them there.
And I agree with all of that completely. And I mean, I think, you know, certainly we got small towns where, you know, a neurologist is never going to set up shop, you know, and we're able to get access to those locations. The only kind of just caveat I worry about a little bit in the future is, you know, like our health system, when we schedule telemedicine visits, you know, first question we ask is, do you have broadband in your home? And if the answer is no, we try to get them into their local clinic and do telemedicine there so they don't have to drive all the way to the tertiary care center. But, you know, do we end up having kind of this two-tiered system if we don't, you know, kind of answer some of these challenges we've talked about with broadband access? And I think it could get, you know, even more as there are more tools and you know, like a digital stethoscope. Is that going to become another question that we ask? It's like, hey, what do you have in your medicine cabinet? Do you have all these digital tools that allow us to do a full broad range of visits in the home? And so we've got to be careful, I think, as we think through these things, to make sure that, you know, financial resources aren't, you know, kind of one of the preconditions to having the convenience of telemedicine in the home.
That's perfect, David. And that's a perfect segue to our final lightning round question of what's here to stay? What should we get rid of from telehealth? What's here to stay? And what are your organizations going to do going forward on telehealth? So I'll start with you, Mike.
All right, I'll start with the end first. We are doubling down on the telefacilitator model. One of the main reasons, and everyone's kind of discussed it, is that it really minimizes the inequities, like, you know, broadband, financial, the literacy. So, and it also helps us use other disciplines and roles within our own clinic, for instance. Even our physical therapy and rehab and what's called occupational therapists, for instance, sometimes they have to go to the participant's home, and now we could send a telefacilitator there, and for something that would have taken like maybe 15-20 minutes in person for one of these therapies, like, hey, let me teach you how to use this piece of medical equipment, or like, let's practice transferring and things like that. This telefacilitator can do that in advance, and then the therapist can like beam in and like double check at the end. So that telefacilitator model, I don't think we're going to get away from that anytime soon. What were the other questions that you asked? Like, you know, what's here to stay?
What's here to stay?
Yeah. I think telehealth is here to stay, like it or not. A lot of those reasons, like that we're very familiar with. You have an increasing population that's living longer, chronically ill. decreasing labor pool, decreasing amount of caregivers, increasing costs. All this really does create demand for innovative models of care, and telehealth is one of many tools that has to be really honed in and optimized. And I'll defer to my colleagues.
Okay, great. Who wants the last word?
I can jump in for a second here because there's
Okay.
actually a QA question that goes right along with this. So I'm going to read it. I don't know if it pops me off the video, but so does virtual care exacerbate existing isolation and loneliness amongst older adults? And I think, yeah, that can, but I think giving a virtual environment, people have now come to accept the virtual world, that it is a form of meeting people and seeing people and being part of the entire package of somebody's social existence. I think it, as long as it's used as a tool and not as the complete package, I think it helps people who feel isolated and lonely by giving them a connection point. It's the same way that they're talking to their grandkids. Why wouldn't they talk to other people in the environment? It's a reason why Peloton exists. People now can feel a virtual gym, and they feel connected to people, and they feel connected to those people on the screen who are motivating them to work out. So I think there is a definite positivity to all of this. I think it's just, it has its place and it has its usage, and we need to just make sure we find that happy place, that happy medium between seeing people face to face and seeing people virtually.
Perfect. Thank you so much to David, Mike, Josh, Greg, and Chris. Really appreciate your insights today. And I want to turn it over to Jen DeYoung to close this out.
Thanks, Amy. And yes, thanks to all of you. Just really appreciate you being here today and sharing your time and insights. I just learned so much listening in on this conversation and just really enjoyed the dialogue. So for all of you listening in, thank you for tuning in today. I want to encourage all of you to go to our website at unitedstatesofcare.org. You can access a deep body of work available to support your efforts, including a recording of today's conversation and links to recently published resources we have on virtual care, like our forthcoming playbook on older adults' experience with virtual care. And I hope you all will consider joining us at a future USF Care event. Thanks so much and have a great afternoon. Goodbye.